Yeah.
Good evening. No action today, no cure tomorrow. Welcome to Antibiotics, Savior or to be Saved, the online webinar conducted by Dyuthi College Union 2021 of MOSC Medical College, Colin. Myself, Feba. The celebrate this discovery of penicillin by Alexander Fleming and subsequent development of fungal metabolite into a viable treatment for infections mark it the golden age of antibiotics. However, less than 50 years later, the WHO published its global report on antimicrobial resistance and concluded that without attention, we are heading for a post-antibiotic era where minor infections and small injuries will once again be fatal. November 18 to November 24 every year has been declared as the World Antibiotic Awareness Week by WHO, increased awareness among the general public, health workers and policymakers to stop further emergence and spread of drug-resistant infections. And the theme for the year 2020 is United to Preserve Antimicrobials. Here we are now to discuss the rising crisis of antimicrobial resistance and the role of healthcare professionals in its mitigation. Let me introduce the panelists for our today. The panelists for our discussion today are Dr. T. George Koshi, Dr. Susan Mani ma'am, and Dr. Shireen George ma'am. Let me first introduce Dr. George Koshi, sir. He is a professor in general medicine at MOSC Medical College. He has completed MBBS, MD in General Medicine and Endocrinology from CMC. Welcome to the talk, sir.
Thank you. Thank you very much.
The next panelist for our discussion today is Dr. Shireen George, ma'am. She's a professor in microbiology at MOSC Medical College, Colin. She has done her MBBS from Sri Devraj URS Medical College and MD in microbiology from JJM Medical College, Devandi. Welcome to the talk, ma'am.
Thank you so much.
Thank you so much. The next panelist for our discussion today is Dr. Susan Mani, ma'am. She has done MBBS from Government Medical College, Trivandrum and MD in Pharmacology from Government Medical College, Trivandrum. Welcome to the talk, ma'am.
Thank you.
Once again, I welcome all the panelists and the participants to our webinar, Antibiotics, the Savior or to be Saved. We assure you that this will be an interactive session and the participants are free to raise their questions in the chat box, which will be asked to the panel during the discussion as time permits. So let's start our session. So as a professor from microbiology, let us begin the discussion with Dr. Shireen, ma'am. What is antimicrobial resistance and what do you think are the most contributing factors towards it?
Okay. Good evening, one and all. First and foremost, let me take this chance to thank the Dyuthi College Union for giving us the chance and to take Antibiotic Awareness Week, give it its due importance. Okay, so now coming to antimicrobial resistance. First and foremost, it's very clear from the term antimicrobial resistance to antibiotics. So it's basically, like we all know, antibiotics it's a kind of savior. That is, any patient or any person who is hospitalized, they invariably they do need antibiotics sometime or the other. So, and another thing is right now antimicrobial resistance is a major threat because why is it a major threat? According to the WHO, is mainly because of the lack of new antibiotics. And what are the factors, like Feba asked me, what are the common factors which can lead to antimicrobial resistance? First and foremost is, overprescribing. That is, even if it's a viral infection, overprescribing antibiotics. That is one reason. Second reason is self-medication. There are so many reasons, self-medication. Third reason is polypharmacy, that is using many types of antibiotics at one particular point of time. Then using antibiotics not at its correct dose or not at its correct frequency, nor at its correct time. That is, if you're supposed to take it for 5 or 7 days, some people, that is after 2 or 3 days, what happens? After 2 days, when all the symptoms gets better, they just stop the antibiotic. That is one reason. Then other common reasons are like, again, prolonged therapy. And if in case of, if suppose you're using a broad spectrum, another reason is using of more broad spectrum antibiotics than narrow spectrum, because broad spectrum, yes, covers a lot of different types of organisms. But when they get a particular culture report, they fail to narrow down. So what happens is this is too much use of broad spectrum antibiotics and lesser use of narrow spectrum antibiotics. So that is another most common reasons for factors for antimicrobial resistance. So ultimately what happens when there is antimicrobial resistance, that leads to prolonged stay in the hospital. What do you say? The revenue increases, that is the patient, the cost increases for the patient, etc., etc. So these are the different factors which can lead to factors which leads to antimicrobial resistance.
Now let's move on to Dr. Susan, ma'am. Now, what are the consequences of using high reserve drug for simple common infections?
Good evening, all of you, and thank you once again from my part to the College Union. Am I audible?
Yes, ma'am. Yes.
Okay.
You're audible.
Before we go to the consequences of using high-end reserve antibiotics for common infections, we'll just see what do you mean by which are the common infections that you usually have to tackle with antibiotics, and what do you mean by high-end reserve antibiotics. Okay, now the common infections that we see in our community, for which patients usually, like the doctors usually give antibiotics, maybe for upper respiratory tract infections, your acute bronchitis, acute sinusitis, a simple pharyngitis, your normal flu, or your diarrhea, or your urinary tract infection, or say simple skin and soft tissue infections, all come under your common infections for which commonly antibiotics are prescribed. And earlier, these are all infections where we find that most of these infections, especially for your upper respiratory tract infections like bronchitis or sinusitis, etc., almost 90 to 95% of these infections are viral in origin, where actually no antibiotic is at all needed. So the first question is an antibiotic even needed for all these infections? And for a normal immunocompetent individual, even without an antibiotic, all self-limiting, they will go off within maybe 3 or 5 days. Maybe for bronchitis, where you have persistent cough for more than 2 weeks, usually the cough in bronchitis may stay for 2 or 3 weeks. So the patient gets frustrated and they may demand an antibiotic. But actually speaking, these are all situations where it is viral, you don't need an antibiotic. And if at all it is bacterial, you need an antibiotic, only narrow spectrum or lower an antibiotic only. But what we find, the trend is that most, maybe it is more prevalent in the junior doctors or the doctors who has just come out of the MBBS profession. They tend to increase, they tend to prescribe antibiotics that they have seen their seniors prescribing. They tend to prescribe all these high-end antibiotics. Now, what do you mean by these high-end antibiotics? You have to know which are the antibiotics which come under the classification of high-end antibiotics. Even your normal fluoroquinolones is now considered, which was very, very commonly used in earlier days, is now considered as a high-end reserve antibiotics, which is now said that it should be served or used only for treatment of resistant and complicated infections like it. It was very commonly prescribed for maybe your simple, uncomplicated urinary tract infection. But now the rule has changed that it should be kept as a reserve antibiotic only for complicated infections. Or maybe meropenem or your beta-lactamase inhibitor combinations, especially cephalosporin beta-lactamase inhibitor combinations. Drugs like vancomycin, linezolid, daptomycin, all these come under high-end reserve antibiotic. Now, why they are called as high-end reserve antibiotics is that These are the only drugs available for treatment of dangerous infections for which no other antibiotic is effective. So for simple common infection, there are a lot of other antibiotics which are still effective. When you start treating these simple common infections with these high-end reserve antibiotics, the more the patient is exposed to the antibiotic, the more the chance for developing resistance even to these high-end reserve antibiotics. Once the organism develops resistance to these high-end reserve antibiotics, we are left with no other choice to treat the dangerous infections for which no other antibiotic has been discovered. But the most important problem is that earlier days this was not an issue because we used to treat, I still remember during my PG days when for any simple common infection, the patients were given either levofloxacin or gafifloxacin or some antibiotic combinations. Nobody even gave a second thought about all this because in case a resistance developed, we always had newer antibiotics getting developed. But now we have reached a stage that is after 2000, maybe up to 2000, there were a lot of antibiotic new classes which were developed. But after the year 2000, we find that only a few new antibiotic classes, maybe one or two like linezolid or your lefamine, a few antibiotics only have been developed. And so in case the patient develops resistance to all these high-end reserve antibiotics, we don't have anything to fall back upon. So it is highly dangerous to prescribe high-end reserve antibiotics for simple common infections. Okay.
Okay, ma'am. Also, studies have shown that immunocompromised people, like those with the chronic illnesses, HIV, AIDS, etc., are more prone to infections compared to other people who are immune. So, what is the effect of antibiotic resistance on immunosuppressed population?
Yes, normally, as I said, the difference between immunocompetent and immunosuppressant is that they lack a competent immune system. And in a normal immunocompetent individual, even though we do not give an antibiotic or even though we give antibiotic only for a short period of time, it is not of much concern because your robust immune system is going to take care of the rest of the problem and the patient is going to recover. But in patients who are immunocompromised or immunosuppressed, they are fully dependent on antibiotics to tackle the infections. They do not have an immune system of their own, or they do not have a fully functional immune system of their own. They are fully dependent on continuous antibiotic coverage even when a small infection occurs. So in such individuals, the problem is when you are giving, what we say is the more the antibiotic exposure to the patient, the more the chance of developing resistance. So this continuous usage of antibiotics in these immunosuppressed population helps in progressing or accelerating the development of antibiotic resistance, and combined with the fact that these infections are much more common in developing countries where there is lack of access to proper antibiotic usage, proper antibiotic guidelines are not followed. Even though if these people are prescribed antibiotics, they do not take the full course of the antibiotic because of economic burden and so on. It will add to the problem and it is going to worsen the problem of antibiotic resistance, or it is going to spiral up the problem of antibiotics much more. And one more thing, now these areas where you have a lot of immunosuppressed or HIV populations, these becomes hotspots for antimicrobial resistant organisms, and these organisms may get transmitted to even the normal population, and when they travel to other areas of the world, this can become an important cause of worldwide, or this can become a global threat. So populations where there is a high level of HIV or immunocompromised people, it can add the problem of spreading of the problem of antimicrobial resistance.
Thank you, ma'am. We also request the participants to mute themselves other than the panelists, those who are speaking, because we are facing some sound issues. So we kindly request you to mute yourself. So let's come to George Koshi. Sir, a team of researchers at Rajiv Gandhi Center for Biotechnology recently identified a mutation in a Vibrio cholera strain, which makes it resistant to one of the mainstay treatment of choice for cholera, that is doxycycline. That has made the treatment more cumbersome. Sir, from your clinical experience, what is the extent of spread of antimicrobial in today's scenario and its impact on the treatment?
Thank you very much for giving me this opportunity to talk to all of you. And I think it's a very good initiative that the students have taken. So, for 100% for that, it's good that you're aware of something before you actually start clinical practice. Um, if you ask me extent of antibiotic resistance, I'm not sure of exact figures, but I can tell you what I have seen over working here for the last 10 years. Like both Dr. Susan Mani ma'am and Dr. Shalin were saying, over the last few years, especially probably over the last 10 years, the problem is quite common. It's definitely seen more often because we do have indiscriminate use of high-end or higher-end antibiotics for minor infections. Or, even when they're in the periphery or they're in the secondary care center and they get referred to us, they tend to use fairly complicated antibiotics like piperacillin, tazobactam. We've even had a patient who came with 2 days of meropenem and then coming to us. The problem when you work in a tertiary care center is they would have already been exposed to a number of antibiotics. They may not have completed the course. They may have got increased use, exposure to multiple antibiotics and they may not have completed the course. And they will have very resistant infection, meaning difficult to treat organisms. It may be difficult to find the organism. And when these people come to us, very often they may land up in the ICU and they may go for complications like what we commonly call MODS. It is multiple organ dysfunction. So you have one person who has come with an aspiration pneumonia, but then he may also have diabetes. He may have hypertension. Then for whatever reason, he may become hypertensive and then go for acute kidney injury. All that will make the treatment of the infection much worse. And we may end up having to use antibiotics that we are not very fond of using, or we would rather avoid using, like the colistin. Colistin is an antibiotic we use for resistant UTIs. It's extremely expensive. We avoid using it, but then sometimes you're forced to use it because when you get the culture report, you find that it's sensitive only to that, and you clinically assess the patient and you realize it's going to respond only to that. It is quite common, and it's definitely become more common in the last 5 to 6 years. It is more common in a specialized setting like in an ICU or in a high dependency unit. It is not so common in the ward, and thankfully not so common in the OP. OP, sometimes you get patients who have already been exposed to 2 or 3 things outside, and then you need to start a different antibiotic. Now what happens is, you may have to give a higher dose of the antibiotic. Okay? So previously, like what Dr. Susan Mani was saying, we were giving gatifloxacin, levofloxacin. Previously, levofloxacin 500 milligram once daily was more than enough. Now we end up having to give a dose of 750 milligrams. When I was doing my MBBS and even when I was doing my internship, we never had this molecule called ceftriaxone. We never heard of it. And when we were treating meningitis as undergraduates, we were giving very high dose crystalline penicillin, 20 lakh 2-hourly IV for treating this. By the time I finished the internship and started the MD, finished the PG and started the MD, everybody started talking. I'm talking about early 2000, 2001, 2002 and all. Everyone started talking about ceftriaxone. And everybody started giving ceftriaxone. Now what happened is everybody in the periphery gives ceftriaxone. You have 2-day fever, 3-day fever, they give ceftriaxone. And they give it at a suboptimal dose for a shorter time. They will give 1 gram IV BD for 3 days or 4 days, which is not correct. And finally, when the patient lands up with us, ceftriaxone isn't going to work, and then they have to go for higher end antibiotic. It is pretty widespread, and I'm sure all my clinician colleagues in medicine, surgery, obstetrics, ENT must be facing this problem every day, especially when the infection is more complicated and the patient is more sick and in a ICU setting. It's something we need to be worried about and be aware about. One thing is that antibiotics that we learned only in the pharmacology book, like Septran or nitrofurantoin or Norflox, because people aren't using that, we have slowly started reintroducing it, and actually the infection responds to that. Septran works very well for many things like recurrent UTI. It works very well because the bugs that we have now haven't been exposed to this. Probably 3-4 generations of bugs haven't been exposed to these simple molecules. Yeah, that's my answer.
Thank you, sir. We have lost connection of Sharon ma'am. Hope she will join us soon. So let's go to Dr. Susan ma'am. Ma'am, what are the measures available to tide over the challenge of antimicrobial resistance And to what extent do you think they are prevalent in today's scenario?
Okay, so the measures to tide over antimicrobial resistance, as what everybody says, it is going to overlap more often, like quite a bit. And as we said, antimicrobial, as the saying goes, antimicrobial resistance follows antimicrobial use like a faithful shadow. So whenever you're using an antibiotic, it is a natural tendency for antimicrobial resistance to follow. There is nothing that we can do to stop this antimicrobial resistance. We can only slow down the rate at which antimicrobial resistance is developing. So whenever you're using an antibiotic, definitely antimicrobial resistance is going to follow. So the more you use an antibiotic, the more the chance for antimicrobial resistance. So the main agenda is to cut down the use of antibiotics, for which infections has to come down. So the first and foremost, to prevent antimicrobial resistance, prevent the development of infections. As we all know that in this era of COVID, where people has been wearing masks, where they have been following hand hygiene, they've been following social distancing, we have seen that the number of infections have come down drastically, for which earlier on, all the young during times of maybe school, when the children used to go to school, they used to get recurrent infections. But all that has come down now. So the first and foremost is to prevent infections from developing, either by hand washing or by maintaining social distancing or by immunization or other techniques. So whenever the rate or the number of infections come down, the antibiotic use comes down, and thereby antibiotic resistance will also decline naturally. That is one foremost thing. Second thing, what the CDC mentioned is you track the clusters where antimicrobial resistant organisms are seen, and you prevent the spread, or you take measures to prevent the spread of organisms from that area to another area. The third and the most important factor in preventing antimicrobial resistance is the concept of antimicrobial stewardship, where the physicians or the clinicians in our country are made aware of proper antibiotic usage. To say that it is not that every clinician misuses antibiotics, but even though we are reluctant to comment on this, or we are reluctant to accept the fact that it is widely seen that almost 50 to 70% of antibiotic prescriptions given by clinicians are either inappropriate or not warranted. So what we can do is, at this level, the concept of antimicrobial stewardship, where you prescribe the right drug, or you choose the right antibiotic for the right patient in the right dose for the right duration. So all these things, if you take up, so for monitoring all those things, there's a concept known as antimicrobial stewardship. And under this, you have many factors under this antimicrobial stewardship program. Earlier on, it was the autonomy of the clinicians to decide the antibiotic. Now, under this antimicrobial stewardship program, it is a team which decides which antibiotic has to be given, or you have a team which oversees the correctness of the antibiotic which is prescribed by the clinician. And more often, as I said earlier, there is a rampant use of high-end reserve antibiotics. Even when you students, when you go to your house surgency, it is very simple for you to order meropenem for your patient. You can simply order maybe your daptomycin or your ceftriaxone, sulbactam, any combinations. It is very easy for you people to prescribe for any given patient. But we need to have a system where you have restricted authority. That is, a system has to come where only a few clinicians there is pre-authorization. There should be only a few clinicians who can write all those high-end antibiotics. In case any other doctor has to prescribe these high-reserve antibiotics, they have to get a pre-authorization from the authority before they can prescribe. That is known as restrictive antibiotic policy. Then you have talks like formulary restriction, where every hospital decides which all antibiotics have to be stocked in their hospital. Now, a common problem that we find is we talk about MRSA. When we ask students which are the drugs for MRSA, everybody will say you have vancomycin, teicoplanin, linezolid, daptomycin, and so on. So the students don't understand, what the students don't understand is, suppose you have a patient with MRSA, if you have a formulary restriction where only vancomycin is available, all the clinicians in that area will be prescribing only vancomycin for any patient with MRSA. But if both vancomycin and linezolid is available in that hospital pharmacy, they go on prescribing linezolid for every simple MRSA infection. Now the problem, the importance of linezolid, this is one antibiotic which is still effective for both MRSA as well as for vancomycin, VMRSA, vancomycin and methicillin resistant staph aureus. So if you start prescribing linezolid for every case of MRSA, it is going to develop resistance, because linezolid is again orally effective with good oral bioavailability. There's a higher chance of misuse of such antibiotics. So such factors like formulary restriction, pre-authorization of use of high-end reserve antibiotics, de-escalation of antibiotics. What do you mean by de-escalation is, suppose you want to start a high-end reserve antibiotic empirically for any serious condition. After 2 or 3 days, you again assess the patient and you find that this is where a pharmacology or pharmacological aspects become more important. That is, if you find that the antibiotic that you have prescribed has got high oral bioavailability, which means, I guess everybody still remembers what high oral bioavailability is. Even though if you give orally, it is going to attain the same plasma concentration as when given intravenously. So if you find that the particular antibiotic that you have started to a patient intravenously has got high oral bioavailability, you can easily switch over from IV to oral antibiotics. Okay, and you can, that is known as de-escalation, or you can change from a broad spectrum antibiotic to a narrow spectrum antibiotic once the culture reports have come. So antibiotic stewardship takes into consideration into all these factors, and it urges the clinicians to follow certain antibiotic stewardship programs. And one more thing, every hospital will have an antibiotic guideline, an antibiotic policy, which is usually based on the national antibiotic guidelines. But even though every hospital has an antibiotic policy, we find that only a handful of clinicians actually even refer to those antibiotic guidelines or even follow those antibiotic guidelines. So if we have strict measures where we impose that these antibiotic guidelines have to be strictly followed, to some extent we can easily cut down the problem of antimicrobial resistance. Okay. You're muted, Feba.
Thank you, ma'am. We also have an audience question. Salha wants to ask, will increasing the availability of targeted narrow spectrum helps to restrict the use of broad spectrum antibiotic, and that could help in reducing antimicrobial resistance? And that is in the sense whether increasing the bulk of the target drug prevent the physician from prescribing broad spectrum antibiotic due to the unavailability of the target drug, ma'am.
I didn't quite get you, Feba. Can you repeat your question?
Yes, ma'am. Yes, ma'am. Will increasing the availability of the targeted narrow spectrum drug help to restrict the use of broad spectrum antibiotic, and thus could help in reducing antimicrobial resistance? That is in the sense, the bulk of the target drug when increased, it prevents the physician from prescribing the broad spectrum antibiotic due to unavailability of the target drug. Is it true?
Yeah, that is what I said, formulary restrictions. Every hospital will have a pharmacy where they stock medicines. So if you stock medicines which are more narrow spectrum, which are more in the lower category, rather than stocking high-end antibiotics, just the same example which I gave you earlier, rather than stocking maybe amoxicillin, cloxacillin combination. And formulary restriction also means this is just the start of antimicrobial stewardship. We find that even though we have been talking over and over again of all these drugs, there are a lot of antibiotic combinations which the FDA or your national antibiotic guidelines say is irrational. They have listed out umpteen number of antibiotic combinations which are irrational. But we find that in our hospital, all these antibiotic combinations, especially cephalosporin beta-lactamase inhibitor combinations, which have never been, which doesn't have any rational for the combination, or which is never prescribed or accepted in developed countries, is being very common commonly used in our hospitals. So if we start stocking all those antibiotics, the clinicians will also start prescribing all those antibiotics. So, as what you asked, if you can restrict the formulary, or if we can stop stocking the pharmacy with these broad spectrum antibiotics or these irrational antibiotic combinations, we can definitely or drastically bring down the problem of antibiotic resistance.
Thank you, ma'am. Sir, studies have shown that antibiotic use in poultry production to increase the yield is a contributing factor to antibiotic resistance in human beings. So what do you think are the direct and the indirect risks of having antimicrobial resistance in poultry?
Yeah, this is a problem that has been there for some time. Actually, I remember during my talk, I want to give a lot of credit to Dr. Sharon from community medicine. He helped with the literature research, and he actually produced made a number of articles available for me. So thanks to Sharon. I remember reading in the Hindu 2 years ago, there was a huge Sunday supplement about use of antibiotics in poultry. Now, why do they use antibiotics in poultry? One antibiotic they use is colistin. Now, remember I mentioned colistin is a high-end antibiotic that we use for complicated urinary tract infections. Now, they use antibiotics in poultry to prevent the chickens from falling ill, and they prevent them from getting infections. So they use the prophylactic antibiotic. They mix it in their feed and they give it to them. And what happens is the colistin accumulates in the tissue of the animal, and the colistin also comes out in the waste. So finally, you get colistin residues in the soil and the water, and we tend to take subclinical doses of that when we take it, and we also get exposed to colistin when we consume the tissue and we consume the meat. And they have found, previous studies have found that farm workers, people who are involved in handling the meat, people who are involved in looking after the animals, tend to have a higher rate of antibiotic-resistant infections. And then there is something called horizontal gene transfer, where you get, when some bacteria get exposed to that antibiotic, there will be production of other bacteria that again get the same gene, which makes them resistant to that particular antibiotic. So this question that you asked about using antibiotic in the livestock, especially chickens, is what we have commonly read. But even livestock like possibly pork and cattle, that can happen. One thing that we need to do, like Manimam was saying, is to prevent the infection. We can do is to improve the hygiene in the areas of livestock. So you improve the general cleanliness, you improve the food that's given, and if there is the issue of immunization, you make sure that the particular animal is immunized. So I hope that answers part of the question. What was the rest of your question actually? How it affects that? Again, you have muted yourself. You have muted yourself. Yeah.
Yes, sir. Yes, sir.
Yeah. Okay.
Okay. Thank you, sir. And let me come to Sharon, ma'am. Ma'am, what does antibiotics do?
Okay, I think Susan, I'm very sorry for jumping out of the meeting and coming back. I just had some electricity issues. Okay, so I think Susan has already told you about antimicrobial stewardship. First and foremost, like she said, it is basically it's a coordinated program where it allows us to choose the right antibiotic to be given at the right dose at the right time for the right person for the right infection, so that it does not harm patients as well as future patients. So what we need to remember here is why do we need, like we had already discussed antibiotic resistance, but why do we need an antimicrobial stewardship? That is mainly because of the increasing antimicrobial resistance, poor antimicrobial research, and misuse of antibiotics. So that is the main reason why we need an antimicrobial stewardship program or a team. So first and foremost, very important is support from the administration. That is, we have a lot of infrastructure. If you want to make a team of an antimicrobial stewardship, you need a lot of infrastructure, a lot of money is involved there. So we need a good support from the administrative side. So then second one is you formulate a team, an antimicrobial stewardship team. And who all are there in this antimicrobial stewardship team is mainly, it can be led by either an infectious disease physician, or a clinical microbiologist, followed by other members in that team is a clinical pharmacist or a clinical pharmacologist. Then from the maintenance department, one person. Infection control, a main part of the antimicrobial stewardship team. So once we formulate this antimicrobial stewardship team, so then the next thing is you need to remember that antimicrobial stewardship team does not work on its own. So basically, it's like they go hand in hand. They cannot, survive on their own. They need the help of the infection control, because in order, they will formulate different theories for an antimicrobial stewardship team. And the infection control team will also help us in curbing this antimicrobial resistance. Okay, so once they formulate the team, the next thing that we need to remember is we should have the proper infrastructure. Infrastructure, what I mean by infrastructure is the key role is played by the microbiology department. It's not because I'm a microbiologist that I'm, putting forward the microbiology department, but here the microbiology department plays a very important role, because we can help the clinician first and foremost. Any particular infection, we can help the clinician if they communicate with the microbiology department. We can help them in telling them, depending upon the infection, what is the most common specimen to be collected, how to collect the specimen. There again, the nurses can also be involved, because they are the ones who usually mostly what happens is the clinician just tells them that please collect this so and so specimen. So the nurses are the ones who collect the specimen. So we can help them in how to collect a specimen properly, be it urine or whatever specimen. Okay. So, and then another, that is one way the microbiology department can help. The second way is the proper infrastructure in the microbiology department itself. Like we have a proper backcheck that makes sure that you at least, we have a round-the-clock microbiology personnel in order to, interpret reports, etc., etc. So then the next thing is formulating an antimicrobial policy. That is, there is no point in just formulating a you should have an antimicrobial policy also, so that helps the clinician in choosing which is the, depending upon the infection, which is the correct antibiotic. Like Dr. Susan had earlier said, like in case of cough, for people use different antibiotics, but when we have made an antimicrobial an antibiotic policy, they are depending upon the systems. That is, if it's a skin and soft tissue infection, what are the common antibiotics you can use, rather than going on for higher antibiotics? What are the common antibiotics you can use? So these are the one way in how the infrastructure. Then the next thing is implementing antimicrobial strategies. Strategies, like there are two types of strategies. One is the front end strategy and the back end strategy. Front end strategy is like already Susan had already said about the formulary restrictions. That is, we keep new antibiotics has reserved drugs, and if the clinicians, if they do want to use a particular antibiotic, they should give a particular reason, the definite reason for why they want to use such kind of antibiotics. While the back-end strategy is where they already use, like for example, in case of empirical therapy, that is a critically ill patient, you cannot wait, the clinician cannot wait for the the microbiology report in order to start an antibiotic. So they would have started a broad spectrum antibiotic also. So once what they need to do is they need to wait, that is after 40 to 72 hours, they need to review the antibiotics which they have used. If they've got a culture report, they've for example, a case of abscess. Okay, so abscess, usually what happens, sometimes they would have started drugs like either vancomycin or linezolid. So in this case of abscess, what we have isolated is Staphylococcus aureus, a very good sensitive Staphylococcus aureus, sensitive to drugs like cloxacillin. So what we would advise the clinician is they need to de-escalate, that is de-escalate from vancomycin and linezolid, de-escalate to the next antibiotics, and a narrow spectrum antibiotics. So in order to make sure that, these are ways in how we can curb antimicrobial resistance. And then another thing that the microbiology department can do is selective reporting, or you can even see cascade reporting. Because you've got a microbiology report, a culture report. You've got what is the name of the organism. So somebody is giving meropenem, but we have not reported meropenem. We've got an organism what we have isolated is E. coli, for example, E. coli. So we have the E. coli is a sensitive strain. So we selectively report. That is, there will be first line drugs, second line drugs, third line drugs. So if that particular E. coli is sensitive to the first line drugs, we just report the first line. So if suppose the clinician does ask us that, we want the sensitivity report of, we are giving this antibiotic, we want the sensitivity report of this particular antibiotic. The reason, ask them how is the clinical condition of the patient, because naturally we just see the bacteria, but the clinicians are the ones who see the patient. So we ask them the clinical condition of the patient. If the patient is better and no fever as such, we ask the clinician to de-escalate from the higher antibiotic, ask them to de-escalate to a lower antibiotic. And if the patient is much better, if the patient is given intravenous or parenteral antibiotics, we ask them to shift on to oral antibiotics. So that what happens is, these are different ways in how you can decrease the antibiotic resistance, decrease the stay of the patient, etc. So that is one very important term, that is cascade or selective reporting. And ultimately, another important role of this antimicrobial stewardship team is education. That is education and training. That is all the doctors. It's not just that you take one particular class and you just stop it there. No, it's continuously, just like a CME, continuous medical education. You keep on learning different new things. So continuously educate all the doctors, all the healthcare workers.
Okay, thank you, ma'am. Sir, after COVID-19 has set in, there is an increased trend of developing nosocomiphobia that has led to an increased tendency to visit pharmacy rather than visiting a hospital, and also taking antibiotics, considering them to be prophylactic to prevent COVID-19 after consultation with Dr. Google. So is COVID-19 accelerated threat of antimicrobial resistance, and how do you think this paves way to antimicrobial resistance?
Yeah, actually, this is a problem I was aware of only after I got involved in preparing for a job, because I didn't realize it was so extensive. There are many issues with COVID-19 and not really antibiotic use. There are issues with COVID-19 and treatment of chronic illnesses. Now, what happens is, like today I had a lady who came to me after 1.5 years. Okay? She came to me in June 2019 and landed up in November 2020. She hasn't come any call from the lab. I had no problem, so I didn't come. And she was getting one particular dose of thyroxine, and today she had a heart rate of some 120. I got so worried, I made her do an ECG. I said, stop all the thyroxine, because she hasn't checked anything for a long time. And they come only when they have an acute problem. Extending the same thing. If somebody is on chronic medication, if somebody is on oral antidiabetic agent for diabetes or on insulin for diabetes, they either stop the medication or they come down on dose because they feel they're okay. Now, how is that relevant here? Any chronic infection, chronic condition like diabetes definitely reduces your immunity. That's going to make you more prone for infections. Now, over-the-counter thing is definitely an issue, not only in India, but all over the world. There are 1 or 2 articles I read where they were showing this Google Maps thing, how the thing is progressively increasing over this year itself. What happens is, most of the infections for which they try to take over-the-counter antibiotics is like what Dr. Susan and Shireen were saying, viral. Okay, viral upper respiratory tract infection or just a nose block for which you don't need quinolone, you don't need macrolide, you don't need beta-lactam, and you don't need cephalosporin, but they'll end up going and taking it. Then many times the culprit is the chemist himself, the guy who is behind the counter at the farm, guy or lady. She will say, "Anti some kaika doctor, but Mundo said the sadhanam maru." Because it's a sad thing. You take it inappropriately for a shorter period of time, and finally that particular person may land up with an infection that won't respond to that particular antibiotic. It's definitely a problem, it's definitely increasing, and it's definitely something that people need to be made aware of. Never take an antibiotic unless it's actually prescribed by a doctor whom you're familiar with and whom you've seen, and preferably the person would have examined you. The only thing that you can get away with it, usually throat or ENT or chest, you need the person to be in front of you. You need to look at his throat, or you need to auscultate, practice palpate. Now, suppose you have a skin infection, like you have a cellulitis, or you have an impetigo or folliculitis. That person can show the arm or limb or something by a telemedicine consultation. He can do a Zoom thing or a WhatsApp thing, and you can say, okay, you can try Ampiclox or Cloxid. Those are the only situations where you can safely try that out. Otherwise, it's a very dangerous trend, which I think we should make each of us aware. And we should make people in our own house aware, our parents, our siblings, uncles, aunts, not to go and take an antibiotic because the chemist has told you to. Because that's a very dangerous tendency which can cause problems to the whole community. You can get spread of various yearly resistant bugs. It's definitely an issue which is increasing more now.
Thank you, sir.
Sharon, add a point, Sheba. Before going on to Sharon, can I just add a point? What I find is after COVID-19, in the initial days, we used to find that azithromycin was very commonly prescribed for COVID patients. And it has given the false belief that even though it is a viral infection, an antibiotic like azithromycin is being effective. If azithromycin is being effective in a viral infection, why not for other viral infections also? I think that is one problem which has sprung up because of this COVID and all these WhatsApp informations which has been circulating and patients are taking. And second thing which I just wanted to clarify was, I don't know how true it is. Even I was of the belief earlier that you're not supposed to stop antibiotic unless you finish the whole course. That was the impression that I had. You suppose the doctor prescribes an antibiotic for 5 days or 7 days, you're not supposed to stop the antibiotic unless you finish the whole course. That is going to worsen the antibiotic resistance. But there have been a few papers which I've read which has shown that actually there is no harm in stopping the antibiotic maybe within 1 or 2 days, because what they say is the more you are exposing the antibiotic, more you are getting exposed to the antibiotic, more the chance of resistance. So in an immunocompetent individual, I'm not talking about any immunosuppressed patient or cases like tuberculosis where you are not supposed to stop the antibiotic. Maybe for a smaller, like simpler, commoner infection, what I read is maybe George Kushi sir can.
I've also heard of this.
I've read about this, that there is no harm. That was quite a surprise to me also. There is actually no harm in stopping the antibiotic once you feel that your symptoms are getting better.
There were a few articles that we have even shared on our doctors group, I think, which actually made the situation very confusing. I think most of those articles didn't have very large numbers. That's what I remember. I'm not 100% sure. So I think we'll take each situation as it is. Extending our argument, sometimes we have people in the ward. Sometimes we notice that only when you go for a consultation, person have been getting an antibiotic for 15 days. I mean, they will just forgot to cut the order. It's nobody's fault, but then when you go there as a new person, you go through the whole thing, then you ring up and say, oh God, we forgot to cut the order, and they cut the. So that situation where the person is exposed to the antibiotic longer than necessary, by oversight more often than not, can definitely lead to antibiotic resistance. That's the situation that we have encountered in the ward.
Okay, thank you, sir. Let me come to Dr. Sharon, ma'am. What is antimicrobial susceptibility testing, and how does it help in the treatment of microbial infections?
Antimicrobial susceptibility testing is, like you all know, there are different ways. There is disk diffusion, there is broth dilution, etc. So here, what is important is, like I said, you select the specimen correctly, depending upon the infection. Select the specimen and send it for culture. Once when you send it for culture, you get a particular organism. You test the antibiotics for that particular organism itself. Like, for example, in case of I like staphylococci, so I'll be citing staphylococci more in comparison to others. So in case of staphylococci, most common the drugs that we usually test for are like cloxacillin, ampicillin, penicillin, gentamicin, erythromycin, etc. While in case of, if it is a gram-negative organism like E. coli, Klebsiella, there are other drugs like piperacillin, tazobactam, ciprofloxacin, etc., meropenem, etc. So what is important here is you need to check antibiotics depending upon the organism that you get, and make sure, like I said here, the importance of antimicrobial susceptibility is, again, like I said, selective reporting. That is, you do not, whatever antibiotics you have tested, you do not report all of them. That is, you do, forgive me for saying this, but we do not give the full the chance to the clinician to select which antibiotic, because there again, if they choose the higher antibiotic, that is, if in case of third generation third line drugs like carbapenems, etc., for a small infection, again, that leads to more of antimicrobial resistance. So it is better to
she's having problems with her electricity, I guess. Current I think maybe that is why.
Okay, ma'am. She'll join us shortly. Let me come to Dr. Susan, ma'am. Are people living in different parts of the world susceptible to different strains of antibiotic-resistant bacteria? And how has international travel added on to the challenge of antimicrobial resistance?
Yes, definitely. People living in different parts will have different kinds of resistant organisms. This is very evident from the fact that if you all remember, the organisms which have a higher chance of developing resistance, if you all know which are the organisms which usually have a higher chance of developing resistance, is your maybe Staph aureus, Streptococcus, E. coli, Klebsiella, gonococci are a few organisms which develop resistance very fast. And even though these organisms are quite common in the community, it is not that every part of the world will be having the same number of these resistant organisms. It can vary from 1% to maybe even 60% in different parts of the world. Maybe in one part of the area, you will have only maybe 2% of resistant E. coli. In another part of the world, you will have organisms or E. coli which are almost 60% resistant to the commonly used antibiotics. Okay, so it is based on this, because of this difference in the antibiotic resistance pattern. It is based on this. It is because of this we don't have one common antibiotic guideline for the whole world. That is, it is, even though we look at the antibiotic common WHO antibiotic guidelines, national antibiotic guidelines, we may refer to the antibiotic guidelines. But even though we refer to those antibiotic guidelines for common guidelines, what we usually do is every hospital will depend on their local antibiogram. Local antibiogram means every hospital with the head of the microbiology department, the microbiology department will be giving out information in between, maybe every 6 months or every 1 year, they'll be giving out information saying which are the organisms and which are the antibiotics which are effective against which all organisms in that particular hospital. So from even in one country itself, the antibiotic susceptibility or the antibiotic resistance can vary from one region to the other. So definitely when you are formulating an antibiotic guideline, you have to follow the local antibiograms. And as Feba asked, even though we have different clusters of antibiotic resistance, this international travel, because now it is not as before. There are a lot of people who are traveling, except maybe for this COVID era. Pre-COVID era, there was a lot of international travel, and the resistant organisms used to get carried from one area to another area. And one common example for this is your New Delhi beta-lactamase. Have you heard about this New Delhi beta-lactamase? This is one substance which is found only in India. Now we find that this is even found in other parts of the world like Australia same resistant E. coli, which was only seen in many parts of India, is now almost seen in parts of Europe and other areas. And the main reason for this is there are a lot of international traveling occurring for medical reasons also. There are a lot, because the hospital expenses are much more cheaper in our country. We have a lot of foreign patients coming to our hospitals, and they tend to harbor, they tend to get infected with all these resistant organisms. Not always, maybe they might be symptomatic. They may even harbor asymptomatically these resistant organisms, and when they travel back to their own country, there's a high chance of carrying these resistant organisms with them, and it will help to spread the resistance among worldwide. It has become a global threat now. Okay.
Okay, ma'am. Thank you, ma'am. Sir,
Yeah.
Sir, as medical students and future doctors, what are the advices that you would like to give us first to control this crisis of antimicrobial resistance from your experience?
Yeah, I think the COVID situation is a benefit situation because it has made us aware of infections and how infections spread, and it's made the public also aware of that. So, like both the ma'ams in pharmacology and microbiology were saying, prevention is the best thing. So, you prevent an infection by using hygienic measures. Never touch anything without washing. When you're you need to eat something or you need to drink water, make sure when you come back to the hospital, you wash your hands. And if you put something in your mouth, make sure your hands are clean. And when you have an infection, when you notice that your friend or yourself have an infection, make sure you meet the clinician directly instead of self-prescribing, because self-prescribing is a dangerous thing. Your senior may tell you, your roommate may tell you, just take this, will get better, because it may not suit your infection, it may have helped her, and you end up taking an inappropriate antibiotic for an inappropriate duration and frequency, and then you'll end up with a really difficult infection to treat. So those are two things you can do at your level. And the third thing you can do is to make your people aware of it. When you teach your classmates, you teach your juniors, and very importantly, when you go home, you teach your family members not to take an over-the-counter drug. So that's something that many people do, even like in a semi-urban, like in a rural area. They tend to believe their pharmacist because he's the person who is usually accessible, the chemist is usually accessible. And he gives something and they just take it right. That's a very dangerous thing to do. So these are three things you can do at your level. I think prevention is the most important thing. Hygiene is very important and education is very important.
Okay. Thank you, sir. We have Sharon ma'am back here. Can you share experience when you found it difficult to tackle an infection due to antimicrobial resistance?
Yes, there are a few clinicians when they call us and when they say that we got this particular organism. So like for example, Pseudomonas. Pseudomonas, they've got it in a wound infection, but it is a highly drug-resistant Pseudomonas. So, so what I'll do is I'll ask them the clinical history or how is the patient, because I don't see the patient. So I ask the clinician, how is the patient? So according to them, the patient is afebrile, patient has no fever, but they have, on culture report, they've got this particular organism. So depending upon the organism, I'll tell them, if the patient is fine, patient is afebrile, patient is asymptomatic, what they can do is, in case of Pseudomonas, just clean the wound properly with proper cleaning the wound, keep the wound clean. It's not necessary that maybe it might be that Pseudomonas will be sensitive only to colistin. If the patient is asymptomatic and you get a multi-drug resistant, my personal view would be is just to leave it as such and clean the wound properly, keep the wound clean, and then I ask the patient, that is when they come back for review, just look at the wound. These are a few, not theories, a few instances that I have come across.
Thank you, ma'am, for your experience. Coming to Susan, ma'am, can vaccination be considered as a preventive measure for antibiotic resistance?
Yes, this was something which was quite new to me also. Only when I saw your question, I just sat up and looked about it, because it was something which was quite new to me. As we said, the more number of infections, one second, the more number of infections, the more the chance to use antibiotics. The more the antibiotic use, the more the chance to develop drug resistance. So your main aim should be to prevent infections. And one major way to prevent infection is vaccination. And I'd only heard about vaccinations for other conditions, but now this is a new concept which is catching up. When I talked to Dr. Sherin, she said that we already have a pneumococcal vaccine. And this pneumococcal vaccine is against streptococcus pneumonia. And as you all know, streptococcus pneumonia is one organism which is a common organism causing most of your upper respiratory infections, most of your pneumonia, some of your middle ear infections, and so on. So streptococcus pneumonia is one common organism which causes a lot of these common infections, for which a lot of antibiotics are being used nowadays. So if we can, if all the children or if all the individuals are made to take the vaccine, so that streptococcal infections doesn't occur in these patients, to a large extent, we can curb the use of antibiotics in such patients. Similarly, if, not only bacterial infections, similarly, developing a vaccine for your common flu or influenza, taking an influenza vaccine, because your common flu presents fever or your cough and so on. So every patient who has got fever, they think that this is a bacterial infection. This is a misguided information that if you have fever, you have a bacterial infection, you have to take an antibiotic. Or if you're this again was quite new to me. Even I was under the impression that if your sputum turns yellow or if it turns greenish in color, it most probably has changed to a bacterial infection. But when I learned that this newly, it doesn't necessarily mean the change of the color of the sputum to yellow or green doesn't necessarily mean it is a bacterial infection. It can still be only a viral infection. So vaccinating for even a viral infection like your influenza or flu, to a large extent can curb the use of antibiotics. Same way, similarly for common infections like diarrhea, staphylococcus aureus infections. If you can develop vaccines for all those common infections, for which persons usually take antibiotics, and as John Kushi sir said, there's a lot of prevalence of over-the-counter antibiotics. And I think I have maybe talked about this in your class also. I'm in a family where there is a lot of, all the others I'm the only doctor in my family. Maybe initial days, my husband and in-laws are all engineers, but still, when we go for, when my child develops any diarrhea, the first thing they say, why don't you give them antibiotic? Why are you simply taxing the child? Why don't you start an antibiotic? They pressurize me so much to start an antibiotic, even if it is a simple diarrhea. So if you can develop vaccines for all these simple infections, for which usually patients tend to take antibiotics, you can curb this antibiotic resistance quite a lot. So vaccination is one new concept which is coming up to prevent or curb antibiotic resistance.
Okay, ma'am. Ma'am, it is also a common practice, as mentioned earlier, among the people to buy antibiotics without prescription by referring to Google or some other means, which would in turn lead to antibiotic resistance. So in this scenario, what all steps can be done to increase awareness of antibiotic resistance among the general public?
Yes, now this is something which is again coming up, antibiotic awareness campaigns. Now the WHO has realized that this antibiotic resistance is a very big global threat, and so they have come up with antibiotic awareness campaigns where not only the doctors are kept aware, made aware about proper use of antibiotics, how to properly prescribe an antibiotic. Most of the instances, the doctor is pressurized into prescribing an antibiotic, even though the doctor feels or the clinician feels that an antibiotic is not necessary. Because of the pressure from the public or because of pressure from the patient, they are pressurized into prescribing an antibiotic. So unless you educate the patient, the general public also about the harmful of overuse or misuse of antibiotics, this fight against antibiotic resistance is not going to reach anywhere. I still remember, again I've told in class, I still remember a neighbor of mine who had come to me. He was maybe 2 blocks apart. So his next door neighbor was a physician, a legal clinician from CMC Vellore. So even though I was doing only my PG, this patient was brought to me saying that, can you just prescribe some antibiotic for this child? I said, you have a pediatrician right next to you. Why don't you go to him? I'm just surprised. He said, what the patient said was, our doctor at the boil antibiotic onnum tharula. So it's the patient who wants an antibiotic. Nobody is willing to take some. So any kind of viral infection, the best advice that you can take is you go home, take rest for 2-3 days, have proper hydration. The viral infection is going to go off on its own. But now we are living in a world where we need immediate results. Nobody is willing to wait for 2 or 3 days. We don't have the time. Most of the houses, it is not, we are all nuclear families. So if your child falls sick, you'll have to sit with the child, take care of the child for 2-3 days. We don't have the time for all that. So you just pop an antibiotic into the child's mouth, you send them to school thinking it is going to get over. So that is the problem of this over-the-counter drugs. Many of the patients take these over-the-counter drugs and it has worsened this problem. So unless you educate the public about the need to restrict antibiotics and about the need to stop pressurizing the clinicians to prescribe an antibiotic, this fight is not going to reach anywhere. And for that, the WHO themselves have antibiotic awareness programs. Now there is another program known as the REACT Asia Pacific campaign, where through ASPIC, there is a club known as ASPIC, Antibiotic Stewardship Implementation in the general public. That is Antibiotic Stewardship Implementation Program among the general public, or those are all ASPIC clubs are being developed under the guidance of this REACT group. This REACT group is a group, WHO, or this is a group where this REACT group has its headquarters in CMC Vellore, and it is also under the guidance of Sweden International Agency. And under this guidance, they have developed this ASPIC clubs where they conduct campaigns in every part of the world or every part of the developing country where the general public is also made aware. In fact, we had recently a program, this ASPIC clubs are part of maybe schools or maybe any club, and they create a campaign to create awareness among the general public of that area, so that once the public is made aware of the problems of antibiotic use, they will also stop maybe taking over-the-counter medication or stop pressurizing the doctors for more and more antibiotics. So it is a very important factor that even though we say really important, and I think that is one of the most important things that has to be dealt with, creating awareness among the general public to stop antibiotic use.
Another way that you can stop this over-the-counter is like when you restrict antibiotics, that is without a doctor's prescription illada ee antibiotic kodukkan pattu illennu vechu angane oru rule undakiyal, that is another way people, rather than consulting Google and then getting a name of a particular antibiotic, going to the pharmacy. So if all these kind of antibiotics are restricted in the pharmacy level itself without a doctor's prescription, they will not get such an antibiotic. That will also one way a little bit help in curbing this kind of problem.
I think if you can gain the patient's confidence that there is no harm in waiting for 3 days, it is not, you are not going to die because you are just having an infection. So boosting the patient's confidence by saying you can just wait for 3 days, you can take rest, there is no actual need for an antibiotic, and if you can gain the patient's confidence, I think with time we can maybe put an end to all this problem, at least slow down the problem of antibiotic resistance. And another problem, as Sir said, use of antibiotics in not only poultry, in the veterinary practice. I have a small pug at home, and with almost every other week he has some infection or the other for which take him to the vet, and every time I take him to the vet, he has at least had umpteen number of antibiotics. Every time I take him to the veterinary doctor, he's prescribed one antibiotic or the other, and most of the antibiotics are something which combinations which I find, my God, this is something which I wouldn't even give to actual patients with severe infections. Such high-end antibiotics are being prescribed even for your veterinary, your pets itself. So the use of antibiotics is very rampant among veterinary practice also, which is adding to this problem, I guess. You're muted.
Yes.
I unmuted, ma'am. Ma'am, can you hear me?
Yes.
Yeah. Okay, sorry, ma'am. Sir, there is another audience question. Deepak would like to ask that after the coronavirus outbreak, the masks, sanitizers, PPE kits, etc. have become a part of our lives. There have been reports that widespread usage of masks, restraining public gatherings, etc., to a decrease in the rate of other infections. So to what extent can these personal protective equipments and social distancing help in the spread of infections, preventing the spread of infections?
No doubt it will definitely, especially when we're talking about respiratory infections, like airborne pathogens. If you have social distancing and masks, it will really help to bring it down. We've seen that because, like ma'am was saying, Dr. Fleming was saying, our incidence of respiratory infections among children have come down so much. In fact, pediatricians aren't so busy anymore because we don't get, the sadhana trauma pani and all that children have because they're not exposed and they're not exposed to each other. It will definitely come down. I have not, it is definitely beneficial and it is good if you can practice it long term, especially if you're dealing with immunocompromised people or if you're a health worker who is going to go to people whom you think are immunocompromised, not necessarily people who have any chronic illnesses, or people like the older people, your grandparents, 75 plus, 80 plus, who may or may not have chronic illnesses. If you can practice social distancing when you go there, it's definitely helpful. You can prevent infection. There's one part to his question I didn't understand actually. Emergence could lead a new way for a bigger pandemic in future. I didn't understand what he meant by it. What did he mean there? Does using masks even supposed to be beneficial? That we have already answered. How would it be for a bigger pandemic? I didn't understand that question. Maybe he can just clarify that. That's the only thing that. And there was another question that another of the classmates put about this use of antibiotics among the livestock and poultry. Actually, they have mentioned pharmacies. I think it is a nexus between the poultry people and possibly drug companies. Drug companies may be able to give a large amount of medication at a low cost and in a more crude form for the poultry people and livestock people to use, more than pharmacies and doctors. It's more of an nexus between drug companies and the livestock people, poultry people, especially when you don't have definite rules. I think like late 90s and now probably even till 2012 and 13 and all, we didn't have definite rules from the government ban the use of antibiotics in poultry. Now we have definite legislation saying it's illegal, which is a good step because it will make people more frightened to use antibiotics.
Okay, sir. We also have another question from Stelvin Sabu. That is, do we see the same or a similar scenario of resistance development with the increased use of disinfectants and sanitizers? Okay, Sharon ma'am, can you answer that question?
Do we see the same or a similar scenario of resistance development with the use of disinfectants?
I answered, you don't use disinfectants on human beings. So we
I think he's referring to the extensive use of increasing use of sanitizers.
that is an antiseptic, not a disinfectant. Delvin, you didn't read your pharmacology properly. You can't use a disinfectant.
I think Stelvin just gave a stick and got hit by Susan.
No, I wonder what is this question actually? Something about free radical based destruction.
Could it be
Something to do with the disinfection.
I think Stelvin can only, what do you say, clarify that question.
Okay, sir, his question follows as, is it sensible to assume that in the long term, it might be better to promote bacteriostatic drugs in certain infections in immunocompetent people because we can rely on the body to control the plateaued bacterial population?
Yeah, in certain, like a simple bacterial upper respiratory infection, maybe macrolide will be enough, or uncomplicated UTI, maybe just spindone will be enough, or the trimethoprim sulfamethoxyl. But you have to choose your patient carefully, you have to choose their clinical situation carefully. Because if you give a bacteriostatic drug for somebody who might get a recurrent UTI, like a postmenopausal lady or a stroke lady on a catheter, then you're in for trouble. You can choose your patient and clinical situation carefully and give the bacteriostatic drug. It's definitely worth it. That's everything is quite good.
Okay. Ma'am, let me come to Susan, ma'am. Mohammed Shahil wants to ask that, is it always that antibiotics are given during viral infections? If there is ample rest given with proper hydration, doesn't the individual get better? Because if not, won't there be a case of negligence from the doctor who, when approached for medicine, did not prescribe, but the infection worsened to the patient?
Yeah, this is the main reason why all doctors prescribe antibiotics.
That's true.
The doctors also feel they have taken the time to come and meet me. They have taken one day off to come and meet me. And in case I don't prescribe an antibiotic, and in case they develop any problem later on, won't I be penalized? This is the fear because of which most of the clinicians prescribe antibiotics, even though they know that it is not actually mandatory. Now, what we can do is, what I said is, it is not always that it is a bacterial infection. Usually, bacterial infections, maybe in sinusitis, there is no harm in waiting for maybe 7 to 10 days. Even after 10 days, you find that your infection is not coming down, then maybe you can think that this is a bacterial infection. So what best I feel that the clinician can do to control Alengil, to tackle such patients, maybe you can give a prescription to the patient saying you need not buy the antibiotic now. You can just take this prescription and you can maybe wait for 1 week or so. And if you feel that your problem is not coming down, then maybe after 1 week you can start the antibiotic. Just because the patient came, you don't have to straight away start the antibiotics because of the fear of negligence on your part. If the patient is so adamant that it is an antibiotic, you can have a prescription telling them that they can start the antibiotic only if the infection doesn't come down after 1 week. Okay. So just because you're scared of being negligent, you don't have to prescribe antibiotic for every patient that comes to you. You also have to be strong in what you believe. You can't be pressurized by the patient every time they come to you.
Okay, ma'am. Ma'am, Stelvin has clarified his point that he asked the question in the sense that could we in the future reach a stage where disinfection of instruments and surfaces be ineffective with current use of disinfectants, leading to incompetent sterilization?
He's getting confused with antibiotic resistance and disinfectant resistance. There is no connection with this. What we are talking about is antibiotic resistance. I don't think we'll reach a point where there will be incomplete sterilization, or that is disinfection of instruments will be ineffective. I don't think there will ever be a stage like that, because we are not unnecessarily using antibiotic resistance and this is two different things. I have
a feeling he's talking about, like, previously when we clean the wound, we used to use a lot of betadine. Nowadays they say you don't have to use betadine. If the wound is not obviously infected, you can use saline. And for surface cleaning, I remember when I was doing my internship in PG, we used to use spirit, betadine spirit for any procedure like LP, a pleural trap, or a septic trap. Now the current teaching that they found equally effective is just use spirit or just use ceruleum. That's
Yeah.
enough to clear the surface. I think that's what ceruleum means.
But I don't think that you'll reach a stage where you will find resistance to disinfection anyway.
I hope we don't.
Yeah.
So there is another question that is from Ranjit. Instead of firefighting, why can't we make the public aware about the need of physical fitness, immunity boosting, perfect diet plan for every individual, monitoring the healthcare indicators so that most of the last minute intervention can be avoided? So can you formulate and suggest a plan for that?
That's a very good suggestion from Deepak. And one thing you can do is, I think the students, once you reach your clinical years, especially when you go to the community, once you go to community medicine, you can make them aware. Okay, you can make the community aware of preventing the infection by keeping fit, by avoiding addictions, avoiding bad habits, avoiding sitting in front of the computer and mobile all the time, keeping active. Then you can use you people. I don't know about you specifically, but flash mob. Flash mob is something that's coming very popular. So you can state something before an event starts. Okay, like or before some event, you should do a short video or dance so that people are aware of that. And it's a very catchy slogan that tends to stay in the mind. And the good thing to do is to catch children. Another thing you can target is, like, a very good suggestion, Deepak, is to target school children. So you can organize your teaching program in schools, middle school, like 6th, 7th, and 8th, because they'll teach each other, they'll teach their juniors and seniors, and they'll go and teach their families. They'll teach their parents and their grandparents also. That's a very good suggestion you've given. That's something you can give, because prevention of infection is very important, and one way we can prevent infection is make people aware. So knowledge about good health practices and public education. These are things which you people can do when you're still young and you're in the present stage of education. And I think community medicine can do a lot for that, and they're already doing it, because you have walks, you have health talks, you can have education that is done through newspaper or short interviews with doctors or even medical students on TV, radio. All those things that can be done effectively. It's an excellent suggestion.
Okay, thank you, sir. That was a very interactive session. The more we use antibiotics, the more we lose antibiotics. As we have reached the end of the session, as future doctors, we should start rethinking antibiotics, the savior, ought to be saved. That was a very informative session. I'm sure that all the participants have found this session useful and would join hands in the fight against growing antimicrobial resistance, which is an invisible pandemic. I believe that all the lessons that they take home from here would benefit them all through their life. On behalf of Dyuthi College Union of MOSC Medical College 2021, I would like to extend our gratitude to our panelists, Dr. George Koshi sir, Dr. Susan Mani ma'am, and Dr. Shareen ma'am for their time and knowledge. I would also take this opportunity to thank all the participants who made this webinar successful. Thank you.
Thank you very much.
Thank you.
Thank you so much, and all the best.
Yeah.
Please try and practice what all that you have heard, rather than just attending all these sessions. You have to put it to practice, only then this becomes successful. And one more thing, I just wanted to share this concept of surgical prophylaxis, which I find very useful. We always find that any small surgery that you do, be it even an incision at an age, you go to a surgeon, it is very often that they prescribe 1 week of antibiotics, even if it is a very clean surgery. And the actual rule is that if you are performing clean surgeries, maybe a surgery of the thyroid or a hernia surgery where you don't have any underlying infection, it is really adequate if you can just give a prophylaxis to cover the first 24 hours. Just maybe the most infections are most common during, because we are all doing very sterile surgeries. taking the utmost sterile precautions. So it is very unusual that infection will develop. You have to give an antibiotic coverage for the whole 5 or 7 days. So if all the small things that you can also put into practice when you start practicing, that is, you make sure if you are doing a clean surgery, you don't continue the antibiotic for more than 24 hours. That is maybe one step that we can go forward to achieve all this, rather than just hearing about all this and leaving it. Put it to practice also, definitely.
Okay, thank you, ma'am. We would like to extend our gratitude from our deepest of the heart for accepting our invitation and making this webinar successful. Thank you so much.
Thank you.
Good night.
Good night.
Good night, ma'am.